If your father or grandpa in the home is uncomfortable with his urine issues, he's not happy with the way it's going, he has to get up multiple times in the night, chances are that he's dealing with prostate issues. This is a common age-related condition known as benign prostatic hyperplasia, sometimes exaggerated in few individuals, but as many as 60% people face it after 60 years of age and 90% above 80 years of age. So it is very common, and chances are either you or someone you know in the family or friend circle is facing challenges with it and not getting proper guidance about it. What is the prostate and what is benign prostatic hyperplasia? Prostate is a small walnut-sized gland at the base of your urinary bladder which stores urine, and it encircles the prostatic urethra, meaning the pipe that goes from the bladder up till your penis and outside, leading to urine passage. With age, due to hormonal changes, more dihydrotestosterone, more estrogen, the hormonal imbalance causes the prostate to enlarge and eventually start compressing or narrowing the urinary passage, which leads to a lot of issues. When a person goes for passing urine, they have to sometimes be hesitant and wait before they can start apply a lot of strain and pressure. Once the stream starts, it's very weak. Sometimes it even stops and starts intermittent. Even after completing the whole urination, they feel there is a lot of urine left in the bladder. They don't feel like they have really emptied it, which can be confirmed on studies. Because the urine is not emptied completely, they have to go back within a few hours, sometimes as short as 60 to 90 minutes to pee again. Nighttime, the same symptom becomes very irritating because they have to get up between twice to as much as 5 to 7 times, and every hour the sleep getting disturbed, it becomes very irritating. Now, if these symptoms are mild and early, simple medications like alpha blockers, 5-alpha reductase inhibitors can help. They open up the urine passage a bit, relieving spasms. They try to reduce the prostate by getting the hormonal or enzyme changes better. But if it is long-standing, if it is moderate or too severe symptoms, and medicines aren't helping alone with some lifestyle changes like metabolic correction, then we might have to consider surgery or invasive options. The traditional gold standard surgery for this was TURP, transurethral resection of prostate, where a urologist goes through the urine pipe, through the penile aperture, takes a camera inside, sees wherever the prostate is blocking the pathway, and chips off a major portion of that middle prostate part so that the passage opens up and the urine symptoms become much better. But I am going to talk here about the most minimally invasive novel method, which is prostate artery embolization. Like cardiologists perform coronary angiographies or angiography for the heart, similarly through your wrist or through your groin, upper thigh, we can take a tiny wire into the blood supply specifically of the prostate, known as prostatic angiography, and knock off that blood supply. When you open a choked or a narrow blood supply, that is known as angioplasty. All of us know that. But when you close an open vessel to destroy the blood supply to the prostate, which is so enlarged, it is known as embolization. And that is why this technique is known as prostate artery embolization. Basically, we take very tiny microcatheters as short as 0.4 millimeters diameters or 1.9 French in our language into the blood supply, specifically going to the prostate. We take an angiogram, we assess whether the supply is cleanly going to the prostate. We inject some agents, embolic agents, either particles or liquid glue, medical glue, which can stop the blood supply to the prostate. Even after doing a good job, we are not able to stop the whole supply, and the prostate does get back some supply, but a major portion of it dies, especially the hypertrophied enlarged glands, and the prostate shrinks, opening up the passage and leading to much better urination. There have been many randomized trials which have shown that the results, especially with respect to the patient's symptoms, are as good as surgery, and at least 7 of these randomized trials or level 1 data has proven that, more than that now, maybe 9, that it is as good as surgery in terms of efficacy. The drawback is mainly that the recurrence rates are slightly higher over a long period of time. If you see the 5-year data, if TURP has a recurrence of 5 to 8%, this procedure has a recurrence of 12 to 17%, which is definitely higher. But even at 5 years, if 83% of the people have complete cure with the minimally invasive intervention, and if it is reproducible, meaning those who do have recurrent symptoms can go back for it, it is an amazing intervention. Now coming to the procedure, what do we do in this? The patient gets admitted at a particular point of time. With a short 30 to 60 minute preparation, we take them in the cath lab or the angiography suite. We prepare their wrist or thigh, clean it. After local anesthesia, while they are awake, we take a tiny wire into the blood vessel supplying the prostatic arteries. We navigate it under angiography guidance into those specific blood vessels, and we inject these particles or glue which stops the blood supply of the prostate. In the end, all the hardware is removed. If it's a wrist, we put a small radial band or a bracelet like structure. If it's the thigh, we put a small compressive dressing. Patient can go back home within the next 3 hours on an average. So yes, it's almost a daycare or a OPD based type of procedure under local anesthesia while patient is awake. There's no blade, there's no sutures, there's no scar. A lot of advantages. The work can be resumed the next day, professional work. There's no recovery period to it. There would be very mild spasm or symptoms, dysuria known as prostate post-embolization syndrome. Now that being said, let's come to some other details about this, which I always talk as a script to my patients. The technical success rate is nearly 99% in good hands, meaning 1% of the patients, if we feel that the anatomy is too complex or embolizing this prostate might lead harm to non-target structures like the penis or other areas, we might abandon it and ask you to go for a surgery. The clinical success rate in best hands is again 90% plus. Prostate center data is 92%. Personally, we have seen 90% plus rates. And the only major durable complication risk feared is something known as non-target embolization. Despite doing your checks, despite doing some angiographic maneuvers, occasionally you may see some of these particles or agent going into a vessel where it's not supposed to go to, which is not the prostate, some other organ, and then you are worried. It can lead to something like a penis ulcer, which is one of the commonest manifestations of non-target embolization. But most of these resolve with time in some patients and some conservative measures. Even those are not really deadly complications. So besides that, it is a very good profile, minimally invasive profile. This video is an attempt to create awareness, reach you directly so that you can visit an interventional radiologist besides reaching your urologist and explore this, understand both the options, understand the pros and cons, and then take an informed decision and choose one of the treatment options. So I hope this adds a lot. Very soon we will be making many more videos on prostates, lifestyle changes that we can do, dietary changes, and a lot more about these techniques, some live demos, some recorded edited demos, so that you understand exactly what is done in the procedure room. And after that, till that, stay tuned. Of course, don't forget to subscribe if you don't want to miss them. Stay safe, stay empowered.